Okay, welcome. I'll be doing now the apical views and subcostal views. So we're going to try to review this. Um, so the apical view in most of North American TNE programs, pediatric cardiology program, will have a tendency to kind of flip the sector view on the image for kind of the anatomical representation of the heart. So the soft rule is that whenever the tail of your probe is towards the lower limbs of the patient, you flip the pie kind of inverted to get more of this anatomical view. And whenever your probe is above the nipple line with the kind of tail of the probe towards the head of the patient, like for example, parasternal long, parasternal short, suprasternal PDA view, then typically you get that kind of inverted sector view from the normal sector view, like we saw previously, for example, like this with the marker on top and the probe on top. So here in these views, the probe is basically placed here in the sense. So whatever is appearing next to this part of the image is going to be near the skin, and whatever is going to be more distal to the probe in terms of the scanning sector that you've selected will be kind of distal. And so typically we'll start in the apical view with what we call the apical four-chamber view, which it tells has four chambers, which are typically the right atrium, the left atrium, the RV, the LV. And you obviously want to make sure that you're having a right ventricle on the right side, a left ventricle on the left side. And although it's called a right ventricle and a left ventricle, it's not related to their position within the body. It's really related to their kind of morphology and conformation. So typically, the RV is more trabeculated most of the time, in the sense, unless like there's like severe RV dilatation, which sometimes you can lose some of these trabeculation because of the dilatation. Typically, the septal zone is also more trabeculated versus the LV. The septal zone is very smooth. The left ventricle will have typically two papillary muscles with attachment to the two leaflets of the mitral valves that are coming on the free wall of the left ventricle. You never have septal attachment. The RV will typically also have a moderator band, which is like a band of muscle that will go from the lateral wall to the septum, and the septal leaflets of the tricuspid valve, which has tri-leaflets, will typically attach to the septum of the RV, septal side of the right ventricle. And then you will always have an offset of this tricuspid valve, which is slightly more inferior, or sorry, downward, I should say, compared to the mitral valve. So you always have a portion of what we call the atrioventricular septum. And if you have a defect here, it's called a Gerbode defect, where you have a left ventricle to right atrial shunt, and these right atrium can be subjected to very high pressure and very high volume. And so these patients can go into very rapid heart failure. They also get a lot of RA dilatation, and so they can get a lot of arrhythmias because of that. They can develop clots in the right atrium because the RA becomes so dilated, and because of its contractility properties becomes a bit more impaired. So typically what we'll see the anterior leaflet of the mitral valve, the posterior leaflet of the mitral valve. So you know that this is actually towards a bit the back of the patient. You see it here actually because the cursor is towards the back of the bed or back of the patient. So that's why it's a bit more posterior or inferior. And this is more anterior. You actually see that the other side of the probe is kind of getting closer to the anterior part of the chest. So this is the anterior leaflet. So the septum is actually more towards the anterior portion of the body, while this wall is more towards kind of the posterior end of the body. So you'll see that in the segmentation, or when we look at the LV anatomy, when you're looking at the different walls, this we call this a more of a posterior wall or more of an inferior wall. And this is the septal wall, which is a bit, slightly positioned anterior compared to this wall within the chest. And then you have the lateral wall of the right ventricle, which is one of the most contractile portion of the RV. So that's why we like to see the TAPSE in that zone, which is a marker of RV function, because this is the wall that tends to contract more. And this is the classical view that you're going to use to do what we call the fractional area change of the right ventricle. And now, nowadays there's many centers that will also do which we call a fractional area change of the RV on the anterior posterior view of the RV that we're going to see later, which sometimes we call the TED view. But this is an anterior posterior view, which has basically the posterior wall of the RV and the anterior wall of the RV, which are, very contractile too. Like you want to look at the entire body of the RV to understand its contractility, but it's not the most contractile portion of the RV. So the most contractile portion of the RV is really this wall and the septum that typically will bulge into the right ventricle. And that's why the American Society of Echo is still recommending that we do the fractional area change in that particular view. Even if there's emerging literature looking at the FAC in the three-chamber view, it's probably not as pronounced in terms of an FAC and contractile power than in this particular view, where you really have like the most muscular portion of the right ventricle body. And then you get to see a lot of the muscular trabecular portion of the septum, and you get a portion here of the septum that we typically call the inlet septum. So if you have a VSD in that zone, you typically will have portion of your tricuspid valve septal leaflet that can be sucked off in this particular zone of the septal defect, and that can sometimes deform a bit your tricuspid valve, and eventually your tricuspid valve develop redundant tissue, which can close off this septal defect. So some of these defects eventually they're followed in cardiology by the cardiologist, and some of them may not even need like emergency closure, because a lot of the tricuspid redundancy will kind of crowd the defect and limit the amount of QPQS imbalance. I wrote here right upper pulmonary vein. It's actually right lower pulmonary vein that we see here, and we often see the descending aorta here. Although sometimes you can catch the right upper pulmonary vein depending on how they're actually connecting to the left atrium. So these are the different views that you see in the kind of apical four-chamber view. If you go very posteriorly, you're going to see your coronary sinus that's going to drain into your right atrium. The coronary sinus is actually an important structure because it drains the entire coronary vessels. And, if your right atrium is under high pressure, because, for example, you have too much flow coming back by your SVC, vein of Galen malformation, or too much flow coming back by your IVC, hepatic hemangioma, or you have high RV and diastolic pressure, like severe PPHN, or severe acute PH or severe chronic PH, and you don't have an offload to your right ventricle, so your RV starts failing. So the PDA starts closing and your RV is subjected to a high afterload, then you're going to have a lot of TR, and then your RA becomes hypertensive, and that can also jeopardize kind of the venous drainage of the coronary arteries. And we know that the coronary flow is depending on the diastolic pressure and the gradient between the diastolic blood pressure and your right atrial pressure. So if you have a rise in your right atrial pressure and a drop in your diastolic blood pressure in the systemic compartment, that transcoronary gradient can become impaired and your coronary perfusion can become problematic. So that's why sometimes when we have some degree of cardiac dysfunction, and we're going to see that our diastolic pressure is very low, we're going to try to find agents that is going to help to maintain diastolic blood pressure in your systemic compartment, and strategies to decrease your RV and diastolic pressure to promote the kind of coronary perfusion. Does that make sense? Fantastic. You also get to see a lot of your RV, your LV, and then if you angulate anteriorly, you'll see your LV outflow tract, and sometimes you can even get what we call the five-chamber view. Although I do find that to get a better five-chamber view, you often need to rotate slightly, especially in the newborn. You need to rotate slightly clockwise to really kind of open up your outflow tract. And then if you rotate a lot clockwise, you're going to end up with like classic, what we call three-chamber view, where you lose your RV and your RA and you just get your LA, LV, and aorta. And that's really a good view to kind of see the continuity between LA, LV, your fibrous continuity between the aorta and the mitral valve, which are kind of abutting to each other, very different than the RV, which doesn't have this fibrous continuity. So you have like a conus to your below, or an infundibulum before your kind of pulmonary valve. So it sits on kind of a muscle sleeve. And so here you see that there's mitral continuity. You see that the LA empties into your LV and eventually pumps into your aorta. So it's a good place to obtain what we call the isovolumetric relaxation time and to see your flow into your aorta and get your Doppler for your LV output. And then you get your two-chamber view. So in this particular schematics, the anterior is here and the posterior is here. In our imaging protocol, we actually get kind of the reverse, where we get the anterior this side and the posterior this side. So just don't mix up and keep your consistency in your scanning and know that where's your anterior and your posterior. So we actually will get typically the probe towards kind of will turn 90-degree anti-clockwise, and with the cursor or the marker towards kind of the clavicula of the patient, which will bring the appendage of the left atrium anteriorly on this side and then the posterior side the other way around. If you would turn the other way around, like 90-degree clockwise, then you would get this particular kind of confirmation on imaging. There's no right or wrong. It depends like what's the standard of like how you do TNEs or pediatric cardiology echo in your lab. In the 4-chamber view, you can also angulate quite anteriorly and then get to see what we call the main pulmonary artery and your RVOT. I find that this is a good view once you get your first sweep to see the anatomical relationship. Make sure that your MPA is crossing your aorta, and then make sure that you don't have like overridings of any of your arteries, and make sure that you don't see any VSDs. So by putting a collar on your septum. So cardiologists, when they're doing structural echo, they'll investigate and probe the septum in every single view to make sure they don't miss any of the VSD, inlet, outlet, paramembranous, or muscular VSDs. Or the last one, which is sometimes classified as a VSD, but is not a VSD, is a LV to RA shunt, so a Gerbode defect, which is not technically a ventricular septal defect because it's not between two ventricles, although many will classify them as ventricular septal defect because one of the hole is part of the ventricle. But as you go anteriorly, you can see your MPA, and you can usually appreciate that your MPA is actually coming more from the left side compared to the aorta. So your aorta, if you remember from your short axis, your aorta in the normal configuration is coming off. Let's go back here. Your aorta is coming off the right side compared to the pulmonary artery. So here is the left of the patient. This is the right of the patient. And this is your aorta. So it's kind of in the middle of the image. It looks like a Mercedes sign, but this is really the right side of the patient. So it's coming to the right of the pulmonary valve, of the pulmonary artery. And the pulmonary valve is more anterior compared to the aorta, which is kind of in the middle. So it's more posterior compared to the pulmonary artery. So when you look at your sweep in the apical view, you can appreciate that your aorta is centrally, and as you go anteriorly and closer to the skin, that's where you see your pulmonary valve, your RVOT, your pulmonary valve, and your MPA show up. And it's typically slightly more on the left side of the patient compared to the aorta, which is more central, and it's to the right of the pulmonary artery. Is that clear for you, Laurence? Like when I describe this sequence? Okay, perfect. The ventricles are not made equally. Embryologically, the RV, and the LV don't come necessarily from the same particular organs. And then you get also neurocrest cells that will migrate to kind of provide the electrical wiring of the ventricles. I'm not going to go in embryology here, but in the really early phase of the cardiac looping, there's some embryologists that even tell us that the RV actually comes slightly later than the LV. And so because of that, that's one of the reasons why we see much more frequently a double inlet left ventricle with an absent right ventricle rather than a double inlet right ventricle, which is extremely rare because, the RV comes a bit later in the embryogenesis. The LV has more of that kind of conical shape or bullet shape. It has the continuity between the aorta and what we call the bicuspid valve or mitral valve. We call this a mitral valve because it resembled the hat of popes, which I think I have this somewhere. I don't know if I kept it in this presentation, but it's really because of the hat of the popes that looks like it was named a mitral, so it has the same shape. And as you can see, the leaflets come into papillary muscle that will attach on this part of the wall. And then you have on the other side a tricuspid valve, which is set a bit more inferiorly. And you have the interventricular septum, which has like shared fibers between the two ventricles. You get fine crisscrossing of apical trabeculation in the left ventricle, so it's very fine, versus on the right side, it's much more coarser. And so the LV typically has this really much more smoother septal layer. And because of the fact that they share fibers and they share an electrical wiring and they're dependent in terms of, the LV being dependent for its preload on what's happening on the right ventricular side and eventually in the pulmonary blood flow. Once you start having like failure on your RV compartment or vice versa on your LV compartment, you're going to be impairing the other side eventually too. So you have to keep an eye on that. So the LV contracts mostly towards the inside, so circumferentially, and there's like a torsional movement to it. So they have rotational properties. So it's a bit like a ringing effect. So think of a towel that is filled of water and that you actually really ring or say essorage in French. So it has this impact. And typically this motion of essorage or ringing happens to become more mature starting like 20 weeks of gestation and then goes on in terms of maturity up to like term and even in the pediatric life up to adolescent life. So the LV continuously grow and the properties of its function also becomes altered both for calcium handling, maturity, the smooth muscle functioning, the electrical wiring, and all these things. Becomes more and more mature with time. And so we know that the LV and the RV, even of babies that are born prematurely, is very different than what we see in the pediatric life and adult life in terms of its capacity to handle afterload, its dependency on preload, its dependency on heart rate to generate appropriate cardiac output, and its limited ability to compensate for rise in afterload because it's typically facing very low afterload during fetal life because the placenta has low resistance. So the walls typically will get thicker in contraction like any muscle, and this is part of the properties to be able to eject into the outflow tract because if it was not thickening, you would lose some of that property of like narrowing the cavity during the contraction or systole. And then you get these different rotations happening at the base and the apex. And this will depend also. So we say typically that the base will have overall the majority of a clockwise rotation compared to the apex, and the apex will have a counterclockwise rotation when you're looking from the side of the apex. But all the layers of the muscle are actually rotating in different lanes. So it's actually like different fibers that are rotating around each other and that are creating this powerful contraction that eventually generates this forward blood flow. And you can see here how the subepicardium and the subendocardium are actually not rotating in the similar fashion. And these properties of maturity will become more and more present as these patients become more mature. So we get a rotation at the level of the apex, we get a rotation at the level of the base, and the relative difference in these rotation provides you with a property that we call the twist. And then torsion is basically when you normalize it to the length of the ventricle. I hope I'm not telling you a lie. I'm pretty sure. I just want to make sure that I'm not lying to you. So I have another element on torsion and twist. We will validate later. Torsion, LV torsion. LV torsion is usually normalized by length. Yeah. Left ventricular twist, apex to base. Sorry about that. Twist versus torsion of LV. One is normalized to the twist refers to the net rotational difference or the ringing motion, and then calculated by dividing. And then the torsion is normalized to the measure of the LV length. So basically, you take that property. So you have the twist, which is that line here. So the peak twist is basically, the orange line. So this is the apical rotation. This is the basal rotation. And your orange line is basically your apical rotation minus your basal rotation. So you can see that these are calculated in degrees. So it's really a degree of rotation. And you are at 0 here when you're in kind of diastole or the portion of immobile flow. You get your QRS and then you start getting activation. So you get an isovolumetric contraction where you get a bit of like motion that starts, and eventually you get a net apical rotation, which will be positive, and net basal rotation, which goes on the other way. So by nomenclature, it's going to be negative. And your twist is the apex minus the base. So because this is negative, it's like a value minus another value. It becomes more positive. And so this twist, when you normalize it to the actual length of the ventricle, we call it a torsion. And that's mostly used in research evaluation. It's used by, either if you're doing a 3D assessment of the LV, you can get some of these metrics, which are really meant for mostly research, I believe. I don't know that anyone would use this for clinical, but I might be wrong. And then, there's a lot of like MRI, very high tensor MRI that are, looking at these fibers and trying to better understand the cardiac mechanics in some of these patients and better understanding, profile. There's if you have like a cardiomyopathy, heart failure, if you have like myocardial infarction, if you're an adult and things like that, to see if some of these properties may provide us with better information on how the LV is able to adapt. The RV is a bit different. As you can see, it doesn't have this bullet shape that we previously saw. And so its fibers has the inflow or the inlet, the outflow tract, and there's really this muscular cone that surrounds the outflow tract that you can see here. And it has this geometry where it looks like almost like a pyramid or it looks like a camel stomach almost. And you can see that the inflow has a peristaltism towards the outflow tract. You get a lot of that contraction of that wall that I mentioned. So you remember I told you this wall, which is represented here, has a lot of contraction towards the inside. Then you also get a portion of septal bulging within the cavity of the RV. And you also have the free wall, which is the other side that gets contracting towards the inside of the cavity. So actually, this wall is really the wall that is the most posterior. So it's not really the free wall we see here. It's actually the wall that we see from the other view, from the TET view, because this is the anterior wall of the RV and this is the posterior wall of the RV. So because it has more of that longitudinal peristaltism, like a bit of like a jumping motion, that's why we look a lot at how much this tricuspid valve is able to be pulled within the RV cavity as a marker of longitudinal function. Now, if you have a lot of atrioventricular valve regurgitation or insufficiency, so think about the tricuspid valve that is regurgitant a lot. So diseases like where you have like Epstein's anomaly or issue with your tricuspid valve for various reasons, the RV may look like it's having a really good function, like it's actually contracting well, but that's because during systole, it's ejecting most of this load or ejection fraction goes a lot into the RA because the RA is a low pressure chamber. So it's not necessarily sending forward your output, it's actually sending backward. And that's true also for the LV. If you have a lot of mitral regurgitation, like a mitral valve that is like actually regurgitant a lot, then it becomes very difficult to use some of these markers of function like ejection fraction to say, oh, it's a normal LV function because it's actually ejecting a lot backward. So you have to be careful about these caveats when you see a lot of mitral regurgitation or a lot of tricuspid valve regurgitation. You will typically, if you have these significant regurgitation, these patients will have like massive right atriums or massive left atriums. So if you have a relatively normal caliber LA or relatively normal RA caliber, or maybe it's a bit dilated but not massive like an Epstein, typically yes, there's some regurgitation, but it's not to the point that you're not having forward flow. So that's why in these particular patients, calculating RVO, LVO, and looking at the VTI in your outflow tract provides you also with like a good kind of information of whether or not you're having like good forward flow. Same thing if you have a lot of pulmonary insufficiency or aortic insufficiency. Example like pulmonary insufficiency, you're able to eject in your outflow tract, but then if everything is coming back into your RV during diastole, then your absolute forward flow is diminished. So you get less pulmonary blood flow because of that. So patients with Epstein have a double hit. They sometimes can get a lot of pulmonary insufficiency. They can get a lot of tricuspid valve regurg. And even if the RV looks contracting well and able to eject some degree in systole, if everything is coming back down into the RV and diastole, well, you don't really get much pulmonary blood flow, and that can become a big issue. And some of these patients can develop a physiology that's called circular shunt. And Laurence, you definitely should want to read on that to get a better sense of this physiology. Okay. I'm just seeing that my hand is like if it's raising my hand, but I don't want to raise my hand. I don't know how to do that, how to remove that. So let's look at the four-chamber view. So this is are the classical view that we do in the pediatric echo world or TNE echo world. This is a patient here on the side. Typically, most machine will provide you a calibration of you have the probe here, you have the marker here. If the marker is towards the left of the patient, this is the left ventricle. If the marker is towards the left of the patient, this ventricle is on the left of the patient. And if it's a confirmation of the left ventricle, then you know the left ventricle is on the left of the patient. Okay. This looks like an LV. You get a very smooth septal surface. Your tricuspid valve is placed slightly inferior compared to the mitral valve. Your RV looks a bit more triangular in shape with a lot of, coarse trabeculations. And eventually, when you switch your probe to have the marker towards the head of the patient, you now cut into the anterior posterior or anterior inferior view. And so you see here that you have a bit of the liver, you have the posterior wall of your left ventricle, the apex of the left ventricle. You see that little line, which we call sometimes the left ventricular tendon. It's really like a fibrous line. It's not the moderator band. Because if it was the moderator band, it would be the RV. How do you know? It's like a very thin line that doesn't get thicker during contraction. You see the mitral valve opening and closing. So you have the posterior leaflet of the mitral valve, the anterior leaflet of the mitral valve. You see your left atrium. And you can even appreciate that kind of burgeoning of the left atrium, which is the left atrial appendage. And here you have the anterior wall of the left ventricle. On the other side, you get the lateral of the RV. You see the attachment of the tricuspid valve on the free wall of the right ventricle, and you see your nice right atrium, nice left atrium, and you can even appreciate your descending aorta. So one of the key marker of cardiac systolic function that is really by and large used for assessment of the LV function is the LV ejection fraction. There's many ways of assessing by echo the LV ejection fraction. What you need to do is basically quantify the volumes of the LV at the peak of diastole and peak of systole and do a fraction of those. So to quantify volumes, there are multiple techniques. All these techniques assume that the LV is taking a bullet-shaped geometry, which may not be true if you have abnormal septal motion or geometry, or if you have LV hypoplasia, or if you have septal flattening. But most of these approaches will use the assumption that the LV is geometrically looking like a bullet. And so you have to be careful because the EF looks at 2 time points in the cardiac cycle. It looks at the peak of systole, peak of diastole, and sometimes you may have areas of your wall that have segmental anomalies of motion. Much more rare in neonates and pediatrics, much more true in these adults with coronary artery disease and segmental like ischemia. And so they get areas of these muscles that are actually not contracting. And really they're moving because the muscle around it is kind of like working, and we call this tethering. So it's basically if you have like friends that are one of their friend is pulling on your right hand and the other friend is pulling on the other side, you're not moving, but because they're moving you're kind of dancing, but you're actually not contracting. So we call this tethering. And so sometimes your other areas are healthy enough to compensate, and so your EF may look okay. And that's where strain and deformation imaging is allowing you sometimes to detect some of these segmental anomaly, because you're really going to look at the entire wall and seeing if each part are contributing to the contraction. But strain, it's being used a lot in like cardio oncology, because a lot of these anthracycline, doxorubicin, and all these things will have an impact on LV function. It's now more and more in use in the cardiomyopathy world, as well as in the world of heart failure related to coronary artery disease in the adult world. And now it's trickling in the pediatric and neonatal world to better understand how these diseases can impact the LV function. So again, multiple methods. The problem is that they all have a certain range of variability. We typically will use the value of 55% as a cutoff of saying like, okay, it's normal, 55 and more. Some experts say, neonates should have even much higher ejection fraction, like 60, 65. But because there's like variability in the measurements, we'll use like the 55 as our cutoff. And when you have, these patients that you're wondering, it's important to kind of repeat a few times to make sure you get a consistency in your measurements, and then you get an average of these different measurements. I've put here some of the standards of the nomenclature. So if you're, and I think I put it also on the website. I actually created in the section of, let me share the website so you can see. Oh, I'm gonna lower my hand at the same time. So you should see the website. If you go here and you go in the apical view, a lot of what I'm saying is going to be outlined here. So I've actually provided you in the regular nomenclature of the TNE world. So you can see here that in your anterior posterior view, you can even see your nice left atrial appendage. You have the base of the heart. The base of the heart is the zone just under the atrioventricular valve. So if you would have to measure your diameter of your base, it's just under the mitral valve. So you have the base, which is either the base inferior or posterior, or the base anterior, because it's the anterior wall. You have the midsection, you have the apical section, and then the little apex here. And this is the nomenclature that ASC has decided to be able to like really describe if you have segmental issues. So I'll typically either use strain to better understand if you have segmental issues, or I'll actually look at the different part of my wall by hiding, just so that my eyes can concentrate on the segment of interest. So I'll look at the septum, I'll look at the anterior wall, I'll look at the lateral wall, I'll look at the inferior wall, and I'll look at kind of all of these sections to see, are there areas of the ventricles that are struggling? And I do the same for the RV, and I try to do the same even the short axis, which gives you kind of this view from on top. In the fourth chamber, here, you remember we said this wall is more anterior, this wall is more inferior. Actually, am I lying? Yes. More anterior, more inferior. Let me get back to you. I think I told you a lie here. I think I told you a small lie. Just want to validate. I think the septum, nomenclature, apical four chamber. Let me just validate that I have not lied to you. Apical septal, ampheroseptal, ampheroseptal. Okay, no, I'm not lying. Perfect. Always validate yourself when you're in doubt. Septal median. Okay, here. Ampheroseptal, anterolateral. Okay, perfect. So I did lie to you. I'll show you where I lied to you. So here I told you, here this is more anterior and this is more posterior. Actually, if we go by, stop sharing. This is more anterior and this is more posterior actually. So I need to change that first graph. Do you get it? Because this is ampheroseptal, ampheroseptal. So this is more towards the back of the patient, and this is anterolateral. So this is a bit more anterior. So this is the good nomenclature. I'm sorry if anyone is listening to us is getting confused. Keep this as the good nomenclature. I just cross-checked. So this is ampheroseptal, mid-ampheroseptal, or apical. So you can see that it's always basal, mid-apical, basal, mid-apical, basal, mid-apical. So that's how you divide the three segments. And then it's relative to what's the position of the wall. So here it's anterior and inferior, or the back side. Here you're starting to get a bit of your septum. So it's the inferior septal, septal, or inferior septal as well. And versus this is lateral. And because this is in the inferior axis, this becomes anterior as well. And as you're rotating towards your aorta, as you remember your aorta looking at the short axis view, your aorta is a bit more anterior to the body of the RV. So the zone within the aorta is anteroseptal, mid-anteroseptal, and apical anterior, versus here you're really towards the back, so you're inferior lateral, apical lateral. So that's just for the nomenclature, that what you see when you're doing. It's rare in general that we actually have to segment it in the neonates, but it's good to know the nomenclature in case you do end up with some segmental issues. Okay, perfect. So how does it look when we do what we call an ejection fraction by Simpson? Simpson use an equation where you're drawing your LV volumes in both diastole and systole. So here, this is in the apical four chambers. So you want to trace your endocardium when the valve is closed at the peak of diastole. Typically, that's when just at the QRS or just before the QRS. And then at the peak of systole, when you see there's full contraction, and you do this in the four chamber view, and eventually you do this in the two chamber view, and the Simpson will join all these discs together and all these ovals and superimpose them one on top of each other to create an end diastolic volume. So here in the four chamber, when you're tracing it the first time, it assumes that all these discs has a perfect circle, a shape. So for EDV and ESV, same thing for the two chamber, but when it combines them together, it provides you a biplane volume. So you get a biplane in diastolic, biplane and systolic. So if you do 8.666 minus 2.85, you get a stroke volume. And then if you calculate your ejection fraction, which is EDV minus ESV divided by EDV, you get your ejection biplane, which in this case is 67%, which is very normal because it's above 55. Does that make sense to you? Perfect. So again, end diastolic volume is the sum of all these discs at the peak of systole and filling. So when the mitral valve is closed, you trace your endocardial border, and the volume will contain these papillary muscles. So we don't segment the papillary muscles. Same thing for end systolic volume. It's at the peak of contraction. And so that's one of the example of the most classical way and the most standard way of calculating ejection fraction. You can also use strain, which will track your left ventricle in systole and diastole and provide you with this maximal end diastolic volume, minimal end systolic volume based on these assumptions, and then provide you with the ejection fraction. Another method is to actually call something called the 5-6 bullet method. It's been designed to be used in the subcostal view. So you get a short axis subcostal view, but many now will use the short axis parasternal view to do the same thing. So you go to the mid papillary area, you trace at the end of diastole, you trace at the end of systole, and you get the area. So here you see the area is 2.92 centimeters square. The area is 1.24. And how it's calculated, it's basically for end diastolic volume, you take the length in diastole. So what's the biggest length of the left ventricle? You multiply this by the area, so the short axis area, so here, and you multiply by 5 divided by 6, and it gives you the LV end diastolic volume. Why 5 divided by 6? Because it's not a perfect cylinder. So this 5 divided by 6 is kind of the ratio for assuming a bullet shape. And then you can do the same in systole, where you have the systolic area, the length, and then you do 5 divided by 6, multiply these two things, you get end systolic volume. You're going to see that it's not exactly the same values that you get from the Simpson's method. But when you do end up calculating ejection fraction, it's often going to be the very similar result of the fraction ratio. I find, just by experience, that the 5-6 method tends to overestimate slightly the volume that you're calculating compared to the Simpson's method. I think part of it is the assumptions that both of them have in their calculations, because obviously it's not always bullet shape. And in the ejection fraction by Simpson, you're actually able to trace the entire shape in both views. The other thing is that one of the issues and caveat with your Simpson is that sometimes you don't get a nice perfect two chamber, and you sometimes often I find people will foreshorten in the two chamber view, and so that's why you get smaller volumes, because people are not actually really in front of the apex, and so you have to be really careful when you're getting a two chamber view to really make sure that you slide your probe until you make sure you're down enough and you're really in front of your apex, especially for the two chamber when you rotate your probe. And so I find that these are some of the caveats. And so some of the studies are mostly done in the congenital heart population. They found that the 5-6 method might be a bit more correlating with MRI values. And the other thing, that there's slightly less inter-rater variability compared to the assessment of LV function. There's a great talk on YouTube by Dr. Leo Lopez, who wrote the pediatric guidelines of the ASC to get an echo. And he actually gives a talk on YouTube about like all the measurements that we do and how some of them have a lot of variability. And so he addresses this. So I do highly recommend you go and listen to that. Phoenix, you have a question.
Yeah, Sorry, super quick. Just when we're doing the bullet measurement, would you
Yeah.
rather we take it um from the subcostal view or the parasternal view?
In our methodology and and even when we describe it in our own papers, we've always used the short axis. One of the reason is that a lot of the patients we see in our population, uh, I find we get a better aligned short axis in front of the mid papillary muscle, which provides a more accurate kind of tracing of the endocardium. Versus, I find that in subcostal, in some of the patients that we see, we see a lot of preemies, so they have big bellies, they have a lot of air in their bellies because they're on CPAP or they're ventilated. They may have neck, they may have like intestinal intolerance. So sometimes we'll go a bit quicker in the subcostal for these tiny prems because they tolerate a bit less the pressure on their belly. And so if we're able to actually describe well the methodology, I actually prefer that we stay consistent and we stay on the short axis. But it's true that it's been originally described from the subcostal. So I just want you to be aware that the technique has been described that way. And so it's a bit of a variation from the technique that's been originally described.
Okay,
Does that make sense?
thanks.
Perfect. And the Simpsons, just so you know, will divide this ventricle in 20 slices. So that's the typical Simpson algorithm that's being done by most machine and most vendors. So it's about 20 discs that it sums up together. Laurence, you have a question?
Yeah, I just have a question. The Simpsons biplane, where we take the apical four chambers and two chambers, is it possible to do it on single
Yeah.
or just on the
Uh,
machine?
so you so in our license of single in the reading mode, no, it's complicated. We can't. But we can do it
Okay.
on the TomTech
Okay. Okay.
software that we have. So we have the TomTech on in the
Mhm.
office. So if ever we really want to do it on the post processing, you do it on the TomTech.
Yeah.
But I recommend if we really want to do a biplane, you have to go on the machine and do it to calculate the biplane. And it's a question. People, if other people are listening on the line, you can do it on single. It's just our mode of reader. We don't have access to the package. We have to go on TomTech. Okay. So again, this is the representation. So you can see that even when you look at the Journal of American Society of Echo, when they describe the 5-6 method for newborns in TNE, they also recommend to use the short axis view compared to the subcostal view. So it's not something that's like invented out of my mind. It's something that's actually being done in a standard way in many of the literature for the TNE literature because of the reason I mentioned, because subcostal sometimes can become a bit more challenging for to get a perfect round en face view of the papillary muscle. Although we strive to get that. This is the place also that our cardiologist will be looking at the measurement of the hinge point of the valve. So typically it will be looked at the peak of diastole when the valve is at its largest diameter to measure the tricuspid valve or the mitral valve. And it's really looking at the hinge point of the attachment of this valve. So here, this is the mitral when the mitral is nicely open, and this is the tricuspid when the tricuspid is nicely open. And this is where they would measure the diameter. And typically, the tricuspid valve is slightly bigger than the mitral valve during the early neonatal life. We would then put collar on these valves. The collar box has to be before the valve and kind of surrounding the valve because you want to make sure the flow is going through, that there's no aeration going through it. And here you can see there's a bit of a trace tricuspid regurg. I get excited when the volume of the regurgitant jet is actually going beyond half of the cavity. And we call it severe, typically in the newborn, when it reaches the roof of the atrium. Some people will use severe or significant. In the adult world, there's actually very strict criterias to quantify regurgitant jet of these atrioventricular valve. And they have classification for mild, moderate, severe. And it's based on multiple markers. These have not been validated in the neonatal pediatric world. It's very common to see in the first few days of life, just because of the labor and the stress of the labor and the contraction, to have like these like trace mitral regurg and trace tricuspid regurg. And in many babies that are very healthy and kids that are very healthy, we always have slight, little regurgitation that are very physiological and they're not really causing any issues. So here you see that you have nice flow, there's no ileasing, and you even see kind of the flow going towards the LVOT a bit, like the blue in the systolic portion of the cardiac cycle. So you would want to make sure you see the blood flow originating before the valve and going through the valve. Then you can bring your color box to see if you have any regurgitant jet going inside your left atrium, to look at one of the pulmonary veins here and the other pulmonary veins here. This is the place that we would typically Doppler these pulmonary veins. So these pulmonary veins will have multiple phases through the cardiac cycle. You typically have an initial systolic phase and then eventually diastolic phase. So why systolic and diastolic? Because you have the QRS here. So this is during the ventricular systole, and eventually you get a little wave during ventricular diastole. And then you get that little phase that's called atrial contraction phase. So during diastole, the mitral valve will open and the LA will empty very quickly inside the left ventricle if the LV is compliant. And because of that, you get a reacceleration of flow inside your pulmonary veins, because the pulmonary veins will flow directly from the pulmonary vein to the LA to the kind of LV. And then you get a little phase during atrial contraction to here. Sometimes if the LV is not very compliant, you can even see retrograde flow. And the more you get LV non-compliance or LV hypertrophy or LV diastolic dysfunction, you may see that the phase of retrograde flow becomes very prolonged. That has not been validated well in newborns, but it's something that they look for in the adult population for kind of diastolic properties of the LV, but things that require more research in pediatric for sure, because diastology in pediatric is a bit of a kind of emerging field of trying to understand that by echo. So we can get also a view of the, sometimes I called it here right upper pulmonary veins, but it depends. So I'm just going to show you that depends where you are in terms of your angle. Right upper pulmonary vein apical view. So you can sometimes get the right upper pulmonary vein from the apical view, but sometimes you can be mistakenly getting like one of the right lower pulmonary vein, which they kind of come in the same axis. So you see here, it's calling it right upper pulmonary vein, but don't be fooled. There are times that it's the right lower pulmonary vein. You see, it tells you right lower pulmonary vein. So because they're kind of coming together. Let's continue. So here you have it. You can kind of appreciate here a bit kind of how they're coming in different planes. So it's typically low velocity. You get a systolic phase, a diastolic phase. It can be either biphasic or triphasic. And typically, you need to drop your Nyquist or your velocity filter in order to see better the course of this flow, because it's a venous flow and it's typically of lower velocity, unless you have like a big PDA that's flooding your lungs, and then sometimes it can come with a higher velocity. So this is what I meant by the triphasic pattern or the biphasic pattern. Sometimes your S1 and S2 pulmonary venous waves are going to be fused. And this is during diastole, the early phase of filling inside your ventricle. And then when you get your atrial contraction, you can get either a bit of retrograde flow, or it could still be sometimes anterograde, depending on your compliance of your ventricle. But it's normal to have a bit of retrograde flow. It's not abnormal. We also use this view to evaluate the inflow velocities. So here, this is an example. It's a pulse wave Doppler. So we're going to get the instantaneous velocities of the inflow from the mitral valve. So we get the E, or early velocity, and the A, which is the active or atrial contraction, or the late velocity. It's not a distance, it's a speed. And basically, typically, once you're a few days old or a week old, when you're done a big portion of your transitional physiology and your LV is now exposed to the systemic vascular resistances, the PDA has closed, and the LV is remodeling progressively to sustain the systemic circulation. Eventually, your LV will be quite compliant during diastole, and your early phase is when you get a lot of gush of blood flow. in diastole. And so that's typically why you get a very rapid influx of blood, and your velocities in the early phase during the passive relaxation, during the passive filling is much higher than your active atrial contraction. So your E on A ratio is typically above 1 in these patients, but it's very common to see babies in the first week of life to have a reverse of this profile because their LV is still a bit stiff from the fetal circulation. The other thing is when you have a very large PDA in preemie, we know that preemies have much less capacitance to their left ventricle. But when you start having a massive PDA, you get a lot of LE flow. And eventually, because this LE is very distended, when the mitral valve opens, this velocity becomes very high. And so your E on A will be much more above 1, typically. So that's an example in a normal newborn. You can see that you have near equal velocities of your E and your A. And sometimes even your E is going to be a bit slower than your A. And that's still normal in the transitional physiology. Versus here, you can see in a more term baby, that's a 1 or 2 week old. And I know this is a bit of a bigger baby because this is 1 centimeter, 2 centimeters, 3 centimeter, 4 centimeter, 5 centimeter, 6 centimeter. And a 6 centimeter heart is more term infant. That's kind of, probably, I know this patient was like a few weeks old, like 2 weeks old because he was coming for a murmur evaluation. So this patient has already undergone transition, and you can see the E and the A has now reversed into like a normal kind of physiology format. You can do the same in the RV inflow. Here you can get to see if there's a bit of tricuspid regurg. First, you can get your E on A. They should have similar format. And that's also dependent on the RE filling. So the RE filling is typically from the systemic venous return, plus or minus a component of left to right shunt if you have a PFO that's left to right. It's also dependent on the compliance, and it's dependent, obviously, the tricuspid valve integrity. If you have a tricuspid valve stenosis, these velocities will be very high, right? And you're going to have a very high right atrium, very big right atrium. You're going to have retrograde flow in your systemic veins. And if you have a PFO or an interatrial shunt, your right atrium will decompress into your left atrium. Your RA may not become dilated if your ASD is large. And then what's going to happen with a tricuspid stenosis or tricuspid atresia is the extreme of tricuspid stenosis is that you're going to have a lot of right to left shunt at the atrial level, and your baby is going to be very blue. If you have some degree of tricuspid stenosis and a PFO that's very tiny, you will get a bit of right to left shunt at the interatrial shunt level, but not enough to decompress your RA. And then your RA is going to balloon, become very distended, and you're going to have retrograde flow in your SVC and IVC. And these are patients that will develop hepatomegaly. So you're not going to develop hepatomegaly in the tricuspid atresia because typically they have massive ASD and it's all right to left, right? So that's unlikely that you're going to get a restrictive septum in the tricuspid atresia. It could happen, but it's very unlikely. Just because in fetal life, there's been a tricuspid atresia from the get-go or from like very early on in the pregnancy. And so all the shunt was kind of flowing from the RA to the LA. So the septum never closed off because of this immense flow that was coming from the RA to the LA. So it's very rare that this shunt will suddenly close off during fetal life. So that's another example where you start seeing that in the early life of these patients, they can have like near equal E on A velocity. And most of the time in many of the babies, especially preemies, because they have fast heart rate, these velocities are going to be fused anyways. So this is an indirect marker of diastolic function, both for the RV and the LV. Caveat is that it's never been well validated in the newborn population as well as in the pediatric population. And these patients are undergoing a lot of changes in the compliance of their ventricles because they're still ongoing into their kind of transitional physiology. So it's hard to use that as a clear marker of like, oh, the relaxation is poor. So we're very rarely going to make like management changes based on just this marker. It's going to be kind of an overall picture of the patient. So we're going to look, for example, in a patient with infant of diabetic mother that has a lot of LV hypertrophy. We're going to look at how is the LV able to fill during diastole. Is there systolic anterior motion of the mitral valve? Are we getting like a lot of aliasing or LVOT signs of obstruction? Is the output in the LVOT diminished? Are we getting a lot of left to right shunt at the atrial level? Is my Doppler at my pulse? Is my pulse with Doppler at the atrial level like very high velocity, which tells us that the LV pressure is much higher than the RE pressure? So these would be signs that, oh, this LV is struggling, like I'm having like LV diastolic dysfunction. Maybe I need to act on that and promote the relaxation by, for example, slowing down the heart rate. Same thing on the RV side, like patients who subjected to like significant hypertrophy of the RV because of various reasons, like pulmonary stenosis, RVOT obstruction, pulmonary hypertension, cardiomyopathy. You're going to look, is there a lot of retrograde flow in my SVC and my IVC? Is my IVC very dilated? In my subhepatic veins on the Doppler of the subcostal, am I having a lot of retrograde flow? Do I have a lot of right to left at the atrial level, which tells me that my RV is not compliant when the atrioventricular valve opens? So it's all these things that you're going to look at to try to get a better sense of what's happening to the relaxation properties of my patient. Okay. Same thing when you have tamponade physiology. A tamponade physiology is typically when you have like fluid around your heart. It could be like PPN, it could be high drops with an effusion that comes from the heart failure. It could be because you have pulmonary hypertension. It could be because you have had a trauma, and because of that, you get bleeding in your pericardial sac. So think about a patient who had pacer wires and the pacer wires were removed, and then the patient can be bleeding. Think of a patient that went to the cath lab or went to cardiac surgery and then starts to have like a bit of a bleeding in the pericardial sac. So these patients can go in tamponade physiology. And tamponade physiology is a disease of diastole. And so, not all pericardial effusion will end up with restriction of flow in their diastolic cavity. And so I highly recommend you go into the TNE portion and then you look at effusions. There's a section on effusion, and there's a whole section, and we'll have a talk about like the physiology of tamponade. But there's little effusions that will not restrict the actual flow. So these patients are cardiovascularly stable. They don't have to be drained, but they need to be observed. And they don't have problems with their blood pressure. Their blood pressure are not narrow in terms of pulse pressure. They're not tachycardic. The output is good. But one of the things you would look in patients that you suspect you may have like a tamponade physiology example in this patient. It's, for example, if you're not losing this pericardial sac during diastole. So it means like your LV or your RV is not able to expand fully. The main effect of a pressurized effusion or a tamponade is that you start compressing your right atrium. So all your SVC and IVC flow has difficulty filling your right atrium. And because of that, you can get collapse of your right atrial wall. So that's an example of a very significant effusion in a patient that developed a tamponade. And you can see this kind of wall of the right atrium that's actually like pushing towards the right atrial cavity because the pressure is so high within the liquid around the heart. And that's an indicator that probably there's tamponade. And I don't know if you can appreciate how the heart is dancing in this pocket and how these muscle walls are even not able to kind of open up during diastole. So because of that, this patient will eventually or might eventually develop, cardiovascular instability, and this patient needs to be drained either urgently or semi-urgently, depending on how these patients are in terms of their hemodynamics. The other thing that we sometimes see is typically you don't get a lot of variations in your inflow velocities of your RV or your LV. So this is the LV. You see here, this is the LV, this is the RV. So most patients will not have a lot of variations in these velocities. So it's pretty going to be steady, these velocities, during the breathing patterns. Either if you're most commonly when you're breathing spontaneously, but some of these patients, even intubated, should not get, as you're changing intrathoracic pressures, changes that much in the velocities of these inflow velocities. So if you start having a lot of variability, it means that you may have a tamponade physiology because how these venous return are coming in an erratic way into the ventricles. Okay, does that make sense? So Laurence, I think there's some questions in some of your exams about tamponade physiology, and as a future neonatal hemodynamics, ongoing neonatal hemodynamic specialist, it's something that you need to recognize. What's the difference between a pericardial effusion that has no consequences or physiologically sound, or one that you think is having a tamponade effect. If the patient is, stable, then it's like obviously an immediate discussion with your cardiologist to discuss this patient will need a drainage. If your patient becomes hemodynamically unstable, then you need to go and drain, especially if he's on the verge of going to cardiac arrest. It's an emergency procedure. So when you're looking at apical views, actually in all the views, you're always going to interrogate to see if you have tricuspid regurgitation. Tricuspid regurgitation happens in systole when the atrioventricular valve is closed. So you can see that you get flow from your RV to your right atrium. And so typically a valve, its role, so the role of a valve is to prevent backflow. So an aortic valve is to prevent the flow from coming back from the aorta to the ventricle, LV. Mitral valves to prevent the flow from coming back from the LV to the LA. Same thing. You don't want your RV blood flow to go back to your RA during systole. And so that's what the tricuspid valve is made for. And so when you get a bit of leak, this can happen either because your RV starts to become dilated, so you lose coaptation of your valve, or some of the patients have some suffering of their RV because of asphyxia, some endocardial ischemia. So then the papillary muscle are a bit ischemic, and because of that, you get not as much tension on these leaflets, and so you get a bit of a leak, or some patient physiologically will have a bit of TR that sometimes you can use to estimate the velocity through it. And so for us, it's a marker of importance because if you use the modified Bernoulli equation, and you have a discrete opening, so a discrete TR, you're able to use that to better understand what's the relationship between your right ventricle and your right atrium in terms of the velocity gradient. So you can use that, and this tells you, for example, that the velocity gradient between your RV and your RA, if you're well aligned. So here you can see, I'll just show you an example where you get one complete curve, but probably this patient is either moving or your probe is moving and you're losing your curve. Why? Because your point of interrogation is likely not aligned with your jet anymore. So it's very easy. Like, let's say if I would have measured it here or measured it here, I would assume, oh yeah, my RVRA is only 2 meters per second, but that's not a full curve. When I get my full curve, I actually get 3.54 meters per second. So it's very important to be the most aligned with your jet, to not underestimate these velocities. But already if your velocities are reaching values that are near systemic, you already know that there's like something wrong that is happening, even if you don't have a full curve. You just cannot say to which degree is your RV to RA gradient because you didn't get your full curve. But even if you get like a semi-envelope that has reached 5 meters per second, you already know that there's something kind of disturbing that's happening that you need to investigate. So the Doppler estimates a gradient between the RV and the RA. And because the RV is facing the pulmonary artery in normal configuration, and because your RV will equalize pressure with your PA, unless you have like a pulmonary stenosis or an RVOT obstruction, you can get what's happening in the pulmonary artery. So you plug your velocity, it's 4V square. And then assuming that your RE pressure is between 0 to 5, you add this to your 0 to 5. So in this context, your peak systolic RV pressure is going to be 55 millimeters of mercury, which you can assume that this is going to be the same as your systolic pulmonary arterial pressure, unless you have a pulmonary stenosis or RVOT obstruction. Or if you have a big VSD, like a super large VSD, then your LV and your RV pressure will equalize, right? Because the two ventricles are connected to each other. So in systole, they'll have the same pressure. And so you're basically measuring the pressure in your LV and your RV at the same time, and you're measuring the pressure that's going to happen in your PA and your aorta, kind of. Does that make sense? And really, it's the directionality of your VSD that then tells you a bit more about what's the downstream resistance. So if it's completely right to left, it tells you that, the afterload of that RV is much higher than the afterload of the LV. So it could be completely right to left because there's pulmonary atresia, for example. So then the afterload is very high because the RV has no outlet. So the only outlet is basically through this VSD into the LV and into the aorta. So when you start mixing congenital heart defect into that, you really need to look at where is my red blood cells going and what is truly my TR informing me on. Your TR is typically informing you on what's the RV systolic pressure, but then to assume that it's the same as your PA pressure, you need to make sure the configuration is within normal limit. So in this particular patient who has pulmonary hypertension, he has 119 of RV-RA gradient. So if you add the 5, it tells you that he's like around 125 of RV systolic pressure. So maybe this patient has like severe critical pulmonary stenosis, and it's not pulmonary hypertension that's causing this. Maybe this patient has pulmonary hypertension because of high PVR. Maybe this patient has pulmonary hypertension because of pulmonary vein stenosis or mitral valve disease, and so the pulmonary vasculature is not able to drain nowhere, and because of that, you get backflow in your pulmonary artery. Maybe there's a pulmonary embolus, and so you get obstruction of your pulmonary artery. So then when you have high RV pressure and high pulmonary systolic pressure, that's when you need to go through like all your sequential analysis and then see, well, where's my blockage? Where's the problem? And how am I going to treat that? Does that make sense? Okay. So we plug it into the Bernoulli equation. We assume an RE pressure of 5. We add it, we get 124. It's a bit of a kind of borderline assumption. If you would put like a central jugular venous pressure catheter in patients who have RV failure or high RV pressure, sometimes their RV will become very hypertrophied. And when the tricuspid valve open, your RE will equalize with your RV. And because the end diastolic pressure is high, your RA pressure is not really 5. It might be like 10 actually, because your RA is starting to face like these very high RV and diastolic pressure, unless you have a big ASD that's decompressing your right atrium, and then your right atrium is able to decompress into the LA. But sometimes in these patients with like a pulmonary hypertension phenotype and RV hypertrophy, they actually have much more, and it's not really 5, and it's like more 10. So you have to, we're still using the assumption of 5, but keep in mind that these patients that have like very struggling right ventricle, big right atrium, retrograde flow in the subhepatic veins, well, probably their right atrial pressure is very high. The other thing is, like, for example, if you see vein of Galen malformation or hepatic hemangiomas that are having huge flow through these lesions, they typically will have very high flow towards the right atrium. And if you go and put a UVL in these patients, you'll see that it's like coming back and back and back. Like it's very hard. You need sometimes to suture the UV around, the umbilical vein around the UVL, because the pressure in the right atrium is so high that you get a lot of backflow into your umbilical venous catheter and eventually around your umbilical venous catheter. And this is like an indicator that your RA pressure is very high. So in these patients, sometimes we'll connect the UVL to a pressure line to understand what's happening in terms of central venous pressures. Does that make sense? Okay. So as an example of a patient where we're trying to align our line of interrogation to get a full curve for TR. And then you can see here that you get 97 milliliters of mercury of right ventricle to right atrial gradient. And what you want to measure is not these little hair here or these hair here. It's really like the chin of the actual curve that you want to get to really get like to not overestimate your RV-RE gradient, because it can become very overestimated if I would put my cursor here. Okay, so another example where here we see clearly the tracing. Did we lose Laurence, or is she still here?
Yeah, she's I think it's loading now, but she's coming back.
Her internet has difficulty. Okay, we'll give like a few seconds. We'll finish the apical view and then we'll stop the session.
Can you hear yet? Oh, she's back. Okay, she's good. She's back.
So here you see a nice tracing. You actually see a lot of the systolic flow, and you see some of the inflow. So you can even see in this continuous wave like the E and the A of the tricuspid valve. So you can see the entire systole and the entire diastole, and then you restart systole and then diastole. And sometimes in some of the research marker, we measure this duration, the systolic and the diastolic time, and we do a ratio between systolic and diastolic. And the more your RV is struggling, the more time you spend in systole. So that's one of the marker that sometimes is looked for, like a marker of RV dysfunction when you have TR. Because you remember, I told you if you have a lot of TR, your RV can kind of eject into your RA, and then all these markers of TAPC and FAC becomes a bit more difficult to put into context. So the famous TAPSE is the tricuspid annular plane systolic excursion. It's really the excursion of this tricuspid valve inside the RV cavity as it plunges during the systolic contraction. So you're placing your line of interrogation through the apex and through the attachment of the tricuspid valve to the RV free wall. It has to be, so you cannot have your line like this. It should go through the apex. That's kind of like what the ASC is recommending. And then basically you follow the line. So you locate the line of this attachment and you follow this line and then see what's the maximal motion inside systole. Some people will sometimes add TDI to help you with that, because if it's red, you stop where the red happens, because red means the tissue is coming towards the probe, and then blue means the tissue is going away from the probe. So some people will add TDI for that. And then you have values and normative values. So if you go on the NeoCardio Lab and you go in calculators or in normative value, what I've done, I've actually created a calculator for you guys where you can go into the TAPSE calculator. You have the reference, which is these two references. And basically, in these references, you have the observed values and you have the fitted model. What's the fitted model? Is that they've put all their observed values and they created like an average expected model of what would be the normative measurements. So parameter Z has also like a nice calculator, okay? So this use, so if I put like, for example, 0.5, you get a Z score of 0.8. If you put here 26, and unfortunately, it's only up to 26 weeks because they didn't include these tiny babies. So that will be an interesting thing. We can look for our cohort of patient that we included like 22, 23, 24 weekers. So hopefully we'll be able to publish on our normative value eventually for the 7 to 10 days old of these patients. But for example, if you put 0.5 and 0.5, you see that here 0.8, so it's the same as what they used. So they used what we call the observed values. And if you use their fitted model within the publication, it gives you 0.54. So not a huge difference, but just to keep in mind that what is really the Z-score that you're looking at, because if you look at the publication itself, and I'll try to open for you the publication so you can see the publication so you get a sense of what you're looking at. So the publication here, you can see that it's based on like 14, 12, 15 patients. So these are the observed and these are the predicted values, okay? So just to get a sense that, when you have ranges, you have to keep into context. So we're often looking at values that really you'll be above, -2 or more than 2.0. And what we'll typically use is the observed values, because why? It's the real values of these patients. So even if it's like only on 14 patients, so we definitely need more literature about what are the normals for these patients. Does that make sense for you, Laurence? Or did I go too quick on the fitted and observed?
That's okay.
Perfect, super. So this is the TAPSE. So that's an example. So you get the systolic phase and then you get the diastolic phase. Sometimes you're going to see that the relaxation may even happen in like two motion, especially at the kind of atrial kick. So you see the P wave and you get a little blip where you get an extra like burgeoning of your RV wall during this atrial kick that pushes a bit more flow into the RV cavity. So typically you'll take your line and then you follow the line and you want to go at the peak of that line. Okay, so you want to try to take the line that's the less blurry and the one that is the most crisp to be able to measure it. So that's another example of following your line and really always trying to take the one that's been obtained as much as possible in line with the apex of the patient, like here. And so these are the normative values that I discussed, the TAPSE Z-score calculator. And just to mention that the MAPSE has also been described. This is something we sometimes do for our research project, as you can see, because it's kind of an easy measurement to obtain. It's obtained the same way. You have to cross the apex and go at the attachment of the mitral valve. And there's been values described for the MAPSE. Here I've put you the reference for the MAPSE. Why many EchoLab do not use the MAPSE in their kind of assessment of the LV function. It's because it's looking mostly at the longitudinal contraction, which is a minor contributor to the overall function. FAC concept is that you're tracing the RV at end diastole in the valve closed and at end systole with the valve closed, and you're doing the ratio. So this time you're doing an area and not a volume, because obviously you cannot trace discs because it's not a bullet, the right ventricle. And so values above 30/35%, depending on which reference you use, is within normal limits. So I typically will use above 30 because I find that between 30 and 35, there's a lot of variability, but most textbook will quote 35%. If you really want to calculate an RV ejection fraction, you need to get a 3D echo or an MRI in order to really take into account the entire geometry of the RV. And so here you would be able to kind of trace the segmentation of the RV in diastole and systole, really to take into context the entire conformation of the RV, and then you would be able to calculate your ejection fraction. But that you need 3D echo or MRI to do that. And so here, that's an example of end systolic area where I trace the contour in systole, and then I trace the contour in diastole, and I do the ratio of these areas, and then I get my FAC. You can also do this in this TED view or the apical anterior posterior view. So here you have your right ventricle. You see almost your aorta kind of coming back from the background. You see the conus of the infundibulum of your outflow tract with the pulmonary valve opening and closing. So you can see that there's no fibrous continuity compared to the left-sided portion of the aorta and mitral valve. So the tricuspid valve is not connected to your pulmonary valve. And then you see your anterior wall, your posterior wall, and your inflow portion of your valve. So it's a good other assessment of your RV function. So again, posterior, anterior, RVO, pulmonary valve with the RVOT just under, and tricuspid valve here that is open. And you can also do your area in diastole, systole, and then do your fractional error change. So that's one of the things that is recommended by the TNE guidelines. You can put color, and sometimes you can even get your Doppler at or just below the pulmonary valve in order to measure your RVOT kind of Dopplers. And sometimes you can get TR here. Actually, I find in many of the preemies and newborns, that's where I get the most bang for my buck to get tricuspid regurgitation to velocity. RV, there's also guidelines to measure if the RV is dilated or not. So you can measure the RV base. The base is just under the tricuspid valve when the valve is closed at the peak of diastole. You can measure the RV length, which is from just above the valve to the apex. And you can measure the RV mid diastolic diameter. You can also measure your right atrium to see if it's dilated or not. So here, this is an example of right atrial planimetry. So this is done when the RE is the most filled, and that's when the tricuspid valve is closed at the peak of systole. Same thing for the diameter of the right atrium. Example of planimetry here. Example of doing these measurements for the length, and you can also do the length in systole. And there's normative RV dimensions that are published, and you can access them through parameter Z. And I think I'll stop here for LA volume. We'll restart next time at the LA volume and LA side and go on with the 2-chamber and 5-chamber view. Are you guys still here? Perfect. So Laurence, I'm saying it's already past 12. I think we spoke for close to an hour and a half. So what I'm going to do, I'm going to stop here, and then next time we'll continue at the left atrium, 5-chamber view, ventricular outputs, and then we'll talk about TDIs, and we'll talk about LV mass and output calculation, DPDT, and then go on with the subcostal view. Good? Perfect. I'll stop recording.